along with me, my team, we're really excited to have all of you here tonight. We have two really fantastic presentations, so I'm going to try to quickly cover some housekeeping items so we can get right into our program. So the focus for tonight's session is ROTEM and trauma. This is actually our second series of events focusing on trauma for 2021. And to those of you who are new to our eMERGE events, eMERGE stands for Education Meetings for Expanding ROTEM Guided Excellence. And the aim of the series is to highlight evidence-based best practices for improving outcomes for critically bleeding patients. The core focus of these sessions is to harness the knowledge transfer. Sorry, I just lost my screen. The knowledge transfer of ROTEM guided PBM strategies to enhance patient safety, optimize resources, and reduce costs. So some housekeeping items to cover. First is a survey. As always, we'll be following up with you via email to provide a very short survey. So if you're able to take a few minutes to let us know what you think of tonight's event, we would greatly appreciate that. Next, just a couple of things to point out about this Zoom session. So first of all, the session is being recorded, and the format for the session will be two 30-minute presentations, each of which will be followed by its own Q&A session, where both speakers will take questions from the audience. For any questions that the speakers can't address due to time constraints, we'll be sure to publish a list of questions and answers in a follow-up email. So next are introductions. I'll first quickly introduce our fantastic Werfen team. First from Brisbane, we have Craig O'Sullivan, who's our acute care diagnostics product manager, and Natasha Curie, who's our clinical application specialist, and she looks after the ROTEM training and education across Queensland. Next from Perth, we have Julia Bonzer, also a clinical application specialist. Julia looks after the ROTEM training and education in WA, the Northern Territory, South Australia, and Tasmania. We also have joining us from Melbourne, Azadeh Zargari, our systems specialist who looks after the ROTEM training and education for Victoria. And we have from here in Sydney tonight, Kieran Pickles, our national sales manager, and Peter Samaras, our acute care diagnostics product specialist. And once again, I'm Maggie Harrington, and I look after the ROTEM training and education in New South Wales and the ACT. Finally, I'm excited to introduce our amazing guest speakers. We're honored to have two ROTEM experts presenting for us this evening. Our first expert joining us tonight from South Australia is Associate Professor Dan Ellis. Dr. Ellis is currently the Director of Trauma at the Royal Adelaide Hospital and the co-chair of the statewide South Australian Trauma Service, SATS. He was previously Clinical Director of MedStar, the Emergency Medical Retrieval Service, part of South Australian Ambulance. As well as the trauma role, he now works as a pre-hospital and retrieval consultant with MedStar, as an intensivist in Calvary Healthcare, and as a consultant in the Royal Adelaide Emergency Department. Dr. Ellis is an accredited specialist in emergency, intensive care, and pre-hospital and retrieval medicine, and has worked in critical care in Australia and the UK for over 20 years. Our second presenter is the one and only Dr. Klaus Gorlinger. Dr. Gorlinger is a leading international expert in the management of coagulopathy and hemostatic resuscitation. He has over 26 years of experience working as an anesthetist, intensivist, and hemostasiologist at the University Hospital Essen in Germany. And his main passion of research is the development and implementation of point of care guided algorithms for goal-directed perioperative bleeding management and patient blood management. Tonight, he'll be sharing evidence along with his expertise on ROTEM guided bleeding management in the trauma setting. We're always so honored to have Dr. Gorlinger chair our events, as his expertise is second to none. So please be sure to visit our event page if you haven't already to view the full bios for both of our expert speakers. And that's it for introduction. So without further ado, please welcome Dr. Ellis and Dr. Gorlinger, and I'll hand it over to you, Dr. Ellis, to kick us off first. Thank you so much.
Thanks very much. I'll just get my screen share. So hopefully you can all see the screen. I'm sure I'll be told very quickly if you can't.
Yes,
so thank you very much for the invite from Werfen. And ROTEM is a subject quite dear to our hearts in South Australia. And I wanted to share with you how we've gone in the last really 4 or 5 years from being an institution that even barely knew what ROTEM was, to actually being getting published papers on ROTEM in trauma, and also how it's become an integral part of our service, and how we've achieved that and why we've done that. That's how I'll start, and then I'm going to share with you a little bit of detail on the publications that I've mentioned, and then we'll finish with a quick case, which I think is always quite an enjoyable way to finish, with a few of the ROTEMs in action. So before I start, I'd like to say thanks also to my colleagues, particularly Dr. Foon Gee, who helped with the slides. So I'm just going to get my... So where do we live? Where's South Australia? You all know where it is. For those of you that live elsewhere, it's a big state, lots of people. But one of the key points is most of those people are in sort of one central location, City of Adelaide, and the rest of the community is scattered around a vast distance of land. So 1 million square kilometres, a lot of distance to cover. So with that, we need lots of assets in order to help us reach all corners of the state. And for that, we're very lucky to have a very effective and efficient retrieval service. But as you can probably imagine, with all of the distance involved, our time to the emergency department, and in fact, this slide is from the Australian Trauma Registry, shows the time to the emergency department across Australasia. In fact, each of the letters represents a state, and South Australia is E. So we're looking at a median across Australia, really, of 1 hour and 28 minutes. And obviously, I've previously worked in London, where times are much shorter, and this needs to be factored in. So time really is of the essence, and that's really a central theme that I want to share with you over the course of my talk. So we do have obviously a trauma system, and that trauma system consists obviously of all aspects from the hospital via communications all the way to retrieval and aviation. The Royal Adelaide Hospital, we're quite fortunate, is a new build. You can see there in the corner of your screen from this aerial shot, the little sort of 4 groups of buildings at the side there. That's the Royal Adelaide Hospital. It is a level 1 centre, and we are undergoing RACS verification. Have done it a long time ago, but we're doing it again in March of the following year. It is a modern building. Yes, there's been some issues with the design of the emergency department. It's a whole separate talk on a whole different day. But arguably, the resource rooms are slightly small for trauma, which is a shame. We have 415 ISS greater than 12 a year, and we're quite au fait with major trauma trials. We're obviously part of PATCH, which is now finished. We recruit to Feisty Junior, a bit more on that later. And we're also just recently been selected as the first site in Australia for the TAP study, which is the new Beriplex 4-factor prothrombin complex concentrate study that's being organised out of Texas in the USA. And I'm sure some of the other centres and some of the other people listening will get involved in this trial themselves as well. So we're quite au fait with research. And I thought I'd put this up in terms of time. I've mentioned to you it already takes 1 hour and 30 minutes to get to the ED on a median. And then we are quite fond of time to head CT as a surrogate marker for testing your system. Not much happens these days in modern trauma without a CT, so it's quite a good barometer of how rapid your time to definitive care could be. Not perfect, but certainly a reasonable start point. Once again, our site is E, and this is in the previous ATR registry. And we're reasonably expeditious in South Australia at getting people to the CT scanner. So we have a ROTEM in the ED, and I'll show you some pictures of that in a sec. But essentially, every significant trauma gets an initial ROTEM. That's part of our policy. And one of the things we're looking at right now is time to first ROTEM. That's not been made particularly easy by the fact that the ROTEM machines don't sync with the Wi-Fi, so the clocks, as we found to our detriment, can be different and somewhat variable, and change with daylight saving, which can be a bit of a problem. But that's something that we've really tried to focus on over the last year or so. Here's the pictures, a couple of pictures here. You can see our Rotem machine now. I think we're relatively unique, and I'd be interested to hear if others do this, but our Rotem machine lives in the emergency department. So this, the top left is the Rotem machine sitting next to the blood gas machine in the resus corridor. So it's literally one step away from the resus rooms. We're also quite lucky in the new build. You can see from the resus rooms on the right, the circled screen at the top, and a little bit of a close-up of that screen at the bottom. These are CGI screens that are really very state-of-the-art in the room. It allows us basically to continue the resuscitation with the Rotem growing in the background. So this is really useful. So there's no having to rush or wait for test results or anything like that. You basically load up the Rotem and then you have access to it during your resuscitation. So that's been really helpful, and the CGI has been quite amazing in that regard. So it does truly mean that we can watch in real time, in particular our FibTem A5 grow and make a decision very early on without having to forget or wait for the results to be delivered to us. We have algorithms that are Rotem sensitive, and Rotem's part of our MTP. And we also have our own Rotem transfusion algorithm for adult trauma, which I'm sure is fairly similar to what you guys would possess. We're also quite lucky, physically available in the emergency department. We have a blood fridge, which has ONEG in it, also has fibrinogen concentrate in it, amongst other stuff. Doesn't have any product in it, apart from the red blood cells, but it's also a meter away from the Rotem machine. So we're quite fortuitous in that regard, and we do stock fibrinogen concentrate, as mentioned. We're also a centre that uses Reboa, although we've only really placed one in anger at the moment. It's also something that we have available in our repertoire. So I just want to share with you a couple of bits of information, one of which was this paper that's actually in this month's EMA, and we did it looking at acute traumatic coagulopathy and how that related to all of the work we get from MedStar. So we get most of our complex polytrauma from MedStar. As I've mentioned, it's scattered around the state, and MedStar acts as a hub and spoke and brings it all to us. We decided to look at that. And the data is really quite interesting in that if you're a trauma call who receives blood, so that third column along, retrieval given blood, we found that 82% of these patients had acute traumatic coagulopathy and a 15% mortality. So in other words, it almost allows us to pre-select regardless of the rest of the patient. If a patient comes in from MedStar who's had a blood transfusion in the pre-hospital arena, chances are they're going to have acute traumatic coagulopathy. And so we found that quite interesting, and that's compared to all the general population for that year. This is a year's data. Was only 9.6%, so it's definitely significant. Perhaps not surprising, you might say, but certainly worth coming to terms with. The other paper that I want to drill down in a little bit more detail was our paper that was also in the same copy of the EMA, which is coming out this month, was how a little bit of a drill down on our introduction of point of care Rotem and how it's affected us, and in particular, how it's affected our blood product use and cost of blood. That paper was presented just a couple of weeks ago at the ATS in the blood section. So really, again, standard stuff. There wasn't too much difference between 2016 and 2018, which really, as you're well aware in publications, 2018 already seems like a lifetime ago as far as we're concerned. But that's how long it takes to get data processed and published these days. But we compared it to 2016, where although we had a Rotem Delta in the laboratory, it wasn't part of our repertoire, and we didn't really use Rotem. So it's about as close as we get for having a pre-Rotem. Although I do stress that we did have a Rotem Delta available for use, but it wasn't well publicized. We looked at 2016 plays 2018 on the basis that 2017 was an odd year for us. We moved hospitals, again, another confounder accepted. And we also got our Rotem. We didn't get our Rotem in the emergency department until we moved hospitals. So that was towards the tail end of 2017. So we admitted 2017 data was a bit flawed, and we went straight for a pre and post introduction of Rotem in the emergency department for trauma. And what we showed was quite interesting in that And if you look really at the bottom level there for the cryo, we did show a trend towards an increase in cryoprecipitate use. There were also some, and that was in particular in the severely injured group. So the ISS greater than 40, which was only 45 patients, but also the ISS between 25 and 40. So we did start to show a trend towards the increased utilization of the specific products designed to treat low fibrinogen. But what was also interesting was the cost and use of blood that went down during the same time frame compared to 2016 to 2018. Now, obviously, you'll rightly point out that red blood cells will have no, the Rotem will have no impact on those. So by no means saying this is a slam dunk, but what was definitely interesting was there seemed to be a trend towards decreasing cost for FFP and platelets after the initiation of the Rotem and an increase in cryo. And that reflected in a cost differential as well, with an increased cost for cryoprecipitate and decreases in all the other parameters. So at the very least, there seemed to be more of a paying attention to the effects of the Rotem, a little bit more focus, if you like, on blood and blood product use between the 2 years examined. So as mentioned, it was a trend away from FFP and platelets and towards cryo, which we hope was people looking a bit more conscientiously at blood and blood product use. And in particular, although it was only around 50 patients, those with an ISS of 50 was significantly increased in the use of cryoprecipitate. And we postulated that Rotem has enabled our emergency teams, our trauma teams, to hold, and that's really something that we see even more so now in 2021, that people will hold initiation of just giving patients one-to-one immediately. A lot of the time they will hold because the Rotem is so quick and is ready so quickly, we can withhold giving unnecessary blood products in particular. So we've been very pleased with that. And it's been a very useful adjunct to our armory, really. And that's really the conclusion of the paper. So by no means a closed case, but definitely interesting trends in this field. So I want to move on to a case presentation of ours, which will just run you through a few Rotems. This was a case at Royal Adelaide from earlier this year. Was a 16-year-old, so we have a slightly odd situation. We're not a paediatric trauma centre. We only take from the 16th birthday onwards, for trauma, but from the 18th birthday onwards for medical. So it's a slight quirk, a slight anomaly, but it seems to work reasonably well for us in South Australia. So this 16-year-old lad was on his motorbike coming down a hill and collided with a semi-trailer. It's a good 30-minute drive from where we are in the Royal Adelaide Hospital. And here's a few pictures from the scene. You can see fairly significant trauma and a fairly significant impact and damage to the structures would imply some significant pathology. So he was attended to by MedStar, and MedStar arrived reasonably expeditiously on scene and stabilised the patient after assessing, found the patient with combative head injury, legs were splayed, urethral bleeding, fairly significantly damaged lower limbs, and some chest injuries as well, and was in shock when they got there. They were able to give blood. As I've mentioned, they carry blood and they carry a blood warmer portable, so they're able to give units of blood pre-hospital. Patient underwent a rapid sequence induction, had bilateral finger thoracostomies, was fairly critical at this point. Got some TXA, was managed from a temperature perspective, and had some splints and some binders applied. Noticed some neurological deterioration en route, and so had neuroprotective strategies initiated as well. So we got to us in the resuscitation room at around about 1:15, and now he's about 80 minutes post injury. Remained in shock. Blood pressure was hard to assess, and so had to repeat the fingering of his thoracostomies. Had a rapid volume resuscitation. We have a Belmont rapid fluid warmer. so had some fluids applied, and had an EFAST, which I'll show you in a sec, and was enrolled in our Feisty Junior study, more of which in a sec. So that's his EFAST, and so positive fast with fluid, the right quadrant, and clear pelvic injury. So Feisty Junior, for those of you that don't know, is about early fibrinogen in severe trauma. It's for under 18-year-olds, so we only recruit between 16 and 18, but we've managed to recruit 7 cases out of 48 across Australasia. So we're quite pleased with that as a non-paediatric trauma centre. But as you can see, it really randomises patients to fibrinogen concentrate or cryoprecipitate. When we first started this, we didn't actually have FibConc in the department, so it was our only source of FibConc. But now we have it as a general in the fridge, and so we can use it for the adults as well. So this was his first ROTEM in the resus room, and just interesting really to note that the FibTem, obviously the FibTem A5 is significantly compromised, and also there's a degree of lysis going on. So this is got, as I've mentioned previously, by the time you've got some bloods and booted up the cartridge, done all the necessary bits and pieces, tend to have access to these first ROTEM results. Within maybe 15 minutes post or 20 minutes post arrival, we've got a FibTem A5, which is very useful. So as per the enrolment, he got 3.5 grams of fibrinogen concentrate. He was randomized to the FibConc arm, you may have guessed. He was also considered for a Reboa, which again was quite complex in that he's pediatric, and Reboa is a bit of a fringe item, especially in the pediatric population. But for somebody who seemed to be bleeding to death in front of us, it was opted to at least insert the 7 French sheath in preparation for the Reboa. But as often happens, once the art line was in and some of the resuscitation had been done, the repeat blood pressures were pretty high, and so the Reboa catheter was not inserted. It was just kept on standby in case we ran into difficulty a bit later. He pretty much went expeditiously to the tech suite with that fast, unsurprising perhaps. Didn't go via the CT scan initially, and went and had some surgical control, and found some bowel perforations, but really only went for damage control surgery at this point, with a laparostomy, and went off for a CT scan on the CT scanner, which is on the same floor as theatre, and was then planned to go back for some vascular assessment and some X-fixes. But we were going to do ROTEMs throughout the journey to make sure, as part of the Feisty Junior trial, ROTEMs are required quite regularly, so it's a nice little flag encouragement for us to do the ROTEMs. And we do have ROTEM, a Sigma up in the tech suites as well as in intensive care. So this was his second ROTEM, and this, with the FibTem A5 at 13, he was not given any more concentrate, which was great, and unfortunately went into the CT scanner, which was very shortly after tech suites. You can see by the time he got to the CT scanner, his FibTem A5 was dropping again quite significantly, and so he got a second dose of fibrinogen concentrate, and then went back to tech suites again for this vascular repair, and the FibTem A5 was 11 on this repeat journey to the tech suites. So again, he got no further fibrinogen concentrate. These are the timelines. I've put these timelines up. We audit these on a weekly basis just to show you roughly what time of impact really, and time to arrive in resus, with timings on the right from time of injury and from the door of the emergency department. So relatively expeditious timings, and worked quite well for him. He ended up on ICU.
Just checking to see, it looks like we lost the connection to Dr. Ellis. So we will just see if he's able to join us again. While we're waiting, does anybody want to chime in where you are joining us from, or if you have any particular comments so far about the presentation or any questions? There we go. It looks like you're just on mute, Dr. Ellis. There we go.
Yeah.
Okay, I will let you take it
To.
I'm not sure if maybe if you turned your video off, if it might help the connection.
Okay, let's just have a look. Can you hear me now?
Yep, all good.
And I don't know where we got to on the slides, team. Did you get to this slide?
I think maybe, do you mind backing up just a bit?
That slide?
Yeah, that's good. Thank you.
Okay. I do apologise for that techno. Goodness knows why that happened, but it did. So this was the slide from the ROTEM in the tech suite, which shows that the ROTEM again had improved, and FibTem-A5 up to 11, so no further FibConc was given. And these were the injury times. Just put this time slide up just so you can see roughly the timelines for this patient's journey. And this includes time from injury and time from the emergency department door. So a reasonable journey, we felt. He went to ICU, unsurprisingly, and once again, by the time he got to ICU, perhaps again unsurprisingly, his FibTem-A5 had dropped again, and he received more fibrinogen concentrate, and this improved his FibTem-A5, and he got no further fibrinogen concentrate. He did return to tech suites on a couple of occasions for various procedures, orthopedics, but it was extubated on day 5 and ended up on the ward on day 34, which was great, and discharged to rehab on day 65. So a reasonably complicated journey, but again, a real demonstration of how dependent we've become at the Royal Adelaide on ROTEM for our management of blood and blood products, even outside of clinical trials. So that concludes my presentation, and I'm happy to take any questions as required.
Thank you so much, Dr. Ellis. That was a fantastic presentation. We had a couple questions come in through email. The first of which, what do you feel are the benefits to having the ROTEM in ED compared to having it in the lab?
Yeah, it's a great question, and perhaps at the beginning I wouldn't have been too plussed with it. A lot of the tests are done in the lab, but I guess the question alludes really to how much of a believer you are in point of care testing. No matter how much we try in medicine, even in the standard ED practice, there's nothing quicker than taking a sample, running it through the blood gas analyzer and getting a result. And the same applies to ROTEM. No matter how quick or slick your systems are, there's still a pneumatic tube or a porter, and then it needs to go upstairs and somebody needs to do the test. And in a trauma team setup, trauma teams lend themselves very well, I think, to point of care testing. Largely on the basis that there used to be plenty of hands on deck. So there's always someone to run the ROTEM, and together with having it on the CDI, we think it makes a big difference. So I'm actually a big convert to it. Plus the fact that what I've really noticed is that despite the fact that we can get blood within a few minutes and we can run our ROTEM as soon as we get blood, I still find that it takes us 15 or 20 minutes to get a FibTem-A5. And that's even with the point of care machine. So it's only going to take longer if you've got another bow another string to that bow. So we're quite big believers in it, and it's a relatively easy machine to keep down there. So I'd be very supportive of that.
Perfect. Thank you for that. The next question is kind of right in line with the previous one. As far as implementing the Sigma in ED, what were the biggest challenges you encountered with implementation and getting everyone on board, and how did you overcome those challenges?
Yeah, so look, in terms of getting the machine, we were quite fortuitous because it sort of came with the new build. We were asked if what machines we needed, and I sort of sneakily said Rotem, and then we got one because they were building a new hospital, and it sort of disappeared into the financial black hole of the new hospital. So that was great, but that was arguably easier than getting everyone's buy-in, which is hard. And certainly, I would recommend a few things to make that go smoothly. One of which is don't force it down everyone's throat. Rotem should be an option, and you can't see it anymore on our MTP stuff because we've evolved. But when we first started, there were 2 limbs to our massive transfusion pathway, and that was if you wanted to use Rotem or if you didn't want to use Rotem. So we decided to try and win the crowd by just showing how useful it was and auditing it and publishing on it. And we've gradually won enough people over now across the hospital that now we've taken out the no Rotem limb out of the massive transfusion. But it meant that people at the beginning weren't scared, because if they said to me, oh, I don't know anything about Rotem, then I could just say, well, just go down the non-Rotem pathway. It's absolutely fine. You don't have to change your practice. But after a year or two, they'd be like, oh, I want to learn a bit more about this Rotem because it seems to be going well for everybody else. So I think rule number 1 is don't force it upon anyone. And then get buy-in from the key players. So you obviously need your hematologists on board. I think that's really important. Because they sort of, your blood committee. So we're represented on blood committee, and we've got very good relations with the hematologists. And then, of course, with the rest of the trauma team, which is always an exercise in diplomacy, both during and after traumas. But you need to get your anaesthetists on board, your intensivists on board, your surgeons on board. And everybody really needs to buy into this concept of, look, we're not going to treat this as a needing fibrinogen replacement until we know, and we will know because there's a Rotem currently running, and we'll know in a couple of minutes. And everybody's prepared to buy into that, and it's reasonably effective. So I think don't force it upon people. Do some good diplomacy, and perhaps using the data that we've just published, try and sell it as a cost-saving initiative, and so you can actually save money on wasted product. In particular, frozen cryo. We used to get a lot of cryo down at the beginning for the massive transfusion, and once it's thawed, it's pretty much wasted. Cryo, as you know. So what we would do is say don't order your cryo until you've got your Rotem, which obviously requires. There are some patients who don't fit in that group. Obviously, if somebody's bleeding to death in front of you, you might need to take more evasive action. But as a general rule, there is enough time to wait for this, wait for a FibTem-A5, and that's what we do.
Great, thank you for that. That was really helpful explanation. We have another question. Outside of the Feisty Junior trial, how many Rotems would you normally run on a trauma patient, or how frequently are you rerunning them to check for therapy effects?
Yeah, so we yesterday would be a case in point. We had a trauma patient brought in, ventilated trauma, came in by helicopter, and had a bad pelvis, and not a child, so not enrolled in Feisty Junior, but had an initial FibTem-A5 of 5, so was given fibrinogen concentrate, and that was around about 10 past 2 in the afternoon, and we repeated his Rotem at about 25 past 2, so about 15-20 minutes later, which is outside of Feisty Junior. That says sort of 10 minutes post. So we did about 20 minutes post, and we looked at his FibTem-A5, and it had gone up to 11. So we elected not to give him any more FibConc, and he went up to theatre to be stabilised, and then in theatre we repeated again. And then possibly on ICU, we repeat it again. So probably there's no fixed answer to this, but probably I would say half an hour after product, within half an hour of giving product, I would repeat the Rotem.
Perfect. Thank you for that. And I'll just put a question out there to the audience just to see, out of interest, who possibly has a Rotem in their lab, or anyone potentially using Rotem in the trauma setting that is using an instrument in the point of care setting. If anybody has pros and cons of either one, or if anybody wants to share some of their experience, if anybody wants to speak up now, we have a few minutes before we start the next presentation, or if anybody wants to put some comments in the chat, it would just be interesting to know, those of you out there, how you're currently using the instrument, if you have access to one. It looks like we had another one come in. Let's see. Dr. Ellis, your approach to the use of Rotem in clinical practice resembles that used by the obstetric and gynecology hospital I work.
Good to know. Thank you.
More of a comment than a question.
Yeah, it's very, very relevant though, and we certainly recognise in trauma that I think we're relatively new-ish in inverted commas to this game, and I think the obstetricians and the cardiothoracic teams have been using Rotem a lot more extensively, albeit in a different cohort.
Right. We had another comment come in. We use Rotem, but it's based in our lab. So we'll just see if anyone else wants to share any comments with us. That was all the questions that we had for the moment. So we can go ahead now. Dr. Ellis, did you have any other comments you wanted to make at this time, or we might loop you back in later on if you're able to stay with us till the end?
No, that's perfect. I'll try and stay on if my internet doesn't play up again.
Perfect. Okay, thank you so much for your fantastic presentation. And I see Dr. Gorlinger is there ready to go, so I will turn it over to him now. Thank you so much, Dr. Gorlinger. Thanks, Dr. Ellis.
Yeah, thanks. Thanks also for the interesting presentation from the point of view of Australia. And I know there's a lot of studies are going on in Australia. So I will try to show a little bit where we are also from a scientific point of view, actually. I hope you can see the title slide already. Yeah, yep. So then we are ready to go. And more or less the topic of my talk is bleeding management in trauma. And what do FIRST and Fibrinogen in TIC and Wittig and ITACTIC tell us, and what comes next? I didn't forget Feisty and Feisty Junior, because of course that's Australian studies, and I will just due to the limited time focus on these other studies, because also Feisty is already addressed by then. You heard already about my background from Maggie, so we can make it short with the conflict of interest. There's mainly two. The first and most important is that since 2012, I'm the medical director of TEM Innovations, the Rotem company, and was also a member of the tactic and the international team for the European trauma studies. And we just go back 10 years, because I think there was one very important study from the group from Karin Broy from Royal London, who did a lot of scientific work in the area of trauma. And at that time, he defined or showed that the best definition of trauma-induced coagulopathy is an XTEM A5 amplitude of 35 millimeters or less, because this predicted at best the need for massive transfusion. And we heard already from then that, of course, we have a lot of trauma patients, but there's a minority who really need massive transfusion. And it's always a question how we can identify this population. And we heard already in his presentation, that's very important, that of course, when we see that a trauma patient is in shock, or he might already need it, pre-hospital blood transfusion, where, to be honest, this is rarely done in Germany, not because it's available, but we are a small country from the size, the geographical size, but a dense population. So our transportation times, fortunately, is usually quite short. So that means we try to bring the patient as quick as possible also to the hospital and just do the stabilization which is necessary outside of the hospital. But again, I think this is a very important milestone to see that we can also, with a lab concept, just with one number, identify quite good which patient will run into the problem of massive transfusion. And that was more or less the data behind that. They showed if we have a patient at admission at the trauma bay with an XMA5 higher than 35, you see that nearly none of these patients needed more than 1 or 2 units of red blood cell transfusion. I'm quite sure this half unit or 1 unit of fresh frozen plasma was not necessary in this situation, because we know 1 unit of plasma doesn't have any hemostatic effect. It might have a volume effect. But that means that if we measure at that time and see, okay, there's no trauma-induced coagulopathy, from my point of view, there's no need to give plasma or platelets. And it's the other way around. If we see at admission of the trauma bay, we have already an XMA5 below 35 millimeters, there's an exponential increase in the need of interventions, whatever intervention we do. Very similar, at the same time, also Herbert Schöchel from Salzburg could show that you can also use the FIBTEM. At that time, they still used the A10, you know, between A10 and A5 in FIBTEM. That's just 1 millimeter difference. So you can, of course, nowadays use the A5, but that was 10 years ago, not already so popular. But we see here again, at admission to the trauma bay, there is a good relationship between the FIBTEM result and the need for red blood cell transfusion. So you see, if it's even higher than 12, the chance is nearly 0 that we need a massive transfusion. If it's still higher than 8, the risk is very low, where when it's below 8 or even below 4, then there's again an exponential increase in the need of transfusion. And that just means, okay, we can use it again, as Dan already mentioned, to withhold unnecessary blood transfusion, or we know that we have to be quite aggressive in the therapy of coagulopathy, whatever that means. If that means ratios or a goal-directed approach, that's not answered by these studies, but of course addressed in later studies. A very important point is, again, that not every severe trauma, again, is coagulopathic at admission. As we heard, yes, if the patient is a severe shock, he needed already blood transfusion. It's also very good clinical markers. But also when we look at the data from the German Trauma Register, it's about 25% of all trauma patients who are coagulopathic at admission. And also the European ITACTIC study just confirmed this, that if we look at all trauma patients with an injury severity score higher than 15, it will end up with something about 25%. Of course, again, maybe in Australia, the situation is a little bit different, because sometimes you have really long transportation times. And that, of course, means that the chance that the patient gets coagulopathic is much higher than you have a transportation time of 15 minutes. So what is, of course, still more or less the general concept and was tested in the proper trial is a ratio-based concept. And in this study, they just compared 2 different ratios. The red blood cells are here in the end. So that means you give plasma, platelets, and red blood cells in 1:1:1, or you give 2 times more red blood cells than plasma and platelets, so the more restrictive approach. And of course, the idea of the proper trial was to show that if we are more aggressive with early substitution also of plasma and platelets, there might be a survival benefit. However, this was only shown for the first 6 hours, but there was no survival benefit for 24 hours or even 30 days. There was a trend, but it didn't reach statistical significance. So in the end, I think actually we're still not sure which ratio is the best if we just focus on ratio. And in between is a quite good agreement that we should include a goal-directed approach, which is also recommended in the European guidelines, as soon as possible. It's also from the same group from London 3 years later, where they were just looking, and that was in the so-called ACID study, so activation of coagulation and inflammation in trauma, that they just observe what happens in severe trauma after 4 units of red blood cells, after 8 units, after 12 units, even with a one-to-one-to-one approach. But what they recognized was that if the bleeding was ongoing, there was no improvement by one-to-one-to-one, not from the point of view of lactate as a marker for shock, and no improvement in XSTEM A5 until bleeding was stopped. So again, I think it's much more important to stop the bleeding than just to focus on enough transfusion. And that was even also addressed from the group from John Holcomb in the US, a father of one-to-one-to-one, which published also about 10 years ago, that if we give plasma transfusion to patients who finally don't need a massive transfusion, there was no benefit, not for morbidity and not for mortality, even vice versa. Lung injury increased 12-fold, multiple organ dysfunction 6-fold, and pneumonia and sepsis 4-fold. So there is also potential harm to give plasma and platelet transfusion to all trauma patients, even if only 25% are coagulopathic. So it's very important to differentiate as early as possible in the emergency room if our patient is coagulopathic or not. And also when we look here at data about platelet transfusion, is even a systematic review and meta-analysis of several randomized trials, we don't see any trial with a benefit. There is not a proven harm, but it's a 50% more mortality in the platelet transfusion group compared to the non-platelet transfusion group. And that fits to a lot of studies which has been done in the last years about more restrictive or liberal platelet transfusion, that it doesn't look very good for a liberal platelet transfusion. And the other issue is that we know in between that there's an early platelet dysfunction in trauma, which is not just based on the platelets, it's on soluble mediators like cytokines, which even inhibits the platelets which get transfused. So maybe even the effectiveness is quite low in trauma. On the other hand, and that's also from data from a proper trial, it's very important to fix the problem of the coagulopathy and stop the bleeding. And this is shown here in this data that every 15-minute decrease in time to hemostasis and in time to stop the bleed is associated with a significant improvement in outcome. That doesn't look so big at the first view. When we look at 30-day mortality, it's just a 3% decrease in mortality. And it's the same for acute kidney injury, for lung injury, multiple organ failure, and sepsis. But it's for every 15 minutes. And we know, for example, if we compare ROTEM measurements and standard lab, there's usually a delay for standard lab of 45 to 60 minutes. So that's 3 to 4 times 3%. Now we're talking about 9 to 12%. And if we discuss, for example, that's nicely shown in the FEISTI trial, if we compare fibrinogen concentrate and cryoprecipitate, it's again 30 to 45 minutes delay for cryo. It's again a 3 to 4 times 3%. And in the end, I think that can make a big difference. So again, I think we have to focus to identify as soon as possible if there's coagulopathy or not, and then we have to treat it as soon as possible. So time really matters in severe bleeding in trauma. And that's an interesting study from Nathan White and John Hess from Seattle in the US, because they were hypothesizing that including a test of fibrinogen concentration in the ED might improve outcome. Of course, we all know just testing doesn't improve anything. It helps to identify an issue. And if we don't treat the issue, it will not improve outcome, of course. But the problem is that even a lot of hospitals who are not using ROTEM are even not really looking for fibrinogen. And we know that plasma is not a good source to replace fibrinogen. So in this study, they looked retrospectively at data from 11,000 trauma patients, so a huge database, and only about 7.5% received a blood transfusion in the first 4 hours. And that's a good news already from this patient, 75% get a fibrinogen measurement done, whether this is in the central lab with a cloth method or a ROTEM or a TAC. That was not the point in this study. But what they could show was, yes, there was an association between having fibrinogen results available and mortality. And then they did even a subgroup analysis. So they looked at the difference between patients who get in the end less than 4 units of red blood cells transfused or more. And it's not a big surprise that only the patients with more than 4 units had a survival benefit, because we usually know that the patients who only get 1 or 2 units of red blood cells usually are not already really coagulopathic. And if they are not coagulopathic, there will not be a change in therapy having the fibrinogen result available. However, when we look at the patients with the 4 units or more, there was a survival benefit with an odds ratio of 3.5. So that really is a strong impact to a better management. However, we can also use, again, the fibrinogen measurement or the FibTEM to say, again, there is no coagulopathy and we avoid unnecessary transfusion. So, of course, also in Canada, there was years ago, it's about 5 years ago, published the first trial. That was a trial where they were looking at trauma patients which are in shock. So that was what they used to say, okay, they have a high chance to be coagulopathic. And they were giving 6 grams of fibrinogen, so a quite huge dose, or placebo in the randomized trial, but blindly, not based on a fibrinogen measurement, if it's Klaus method or FibTEM. Then they were looking, of course, on the change in fibrinogen plasma concentration, 28 days mortality, and the incidence of thromboembolic events. And 69% of the patients received the intervention within 1 hour. So that was one question. Is it feasible with fibrinogen concentrate to treat the patient more or less in the golden hour of shock within 60 minutes after hospital arrival? And what they could show that the plasma fibrinogen concentration remained higher in the fibrinogen concentrate group, not a big surprise. And the largest difference was between 2 and 4 hours after the administration. Later on, they come close to the placebo group again, because we all know that after trauma, as an acute phase reactant, for example, after 12, 24, 48 hours, even also in the other patients, fibrinogen will increase. 28 days mortality and thromboembolic complications were similar between groups. I'm always careful with similar, in particular in relatively small randomized trials, but we will look at this. But finally, this study was done to look, is it feasible to get the fibrinogen infused within the first hour of hospital admission. So here we see the data again, that within the first 2 to 4 hours, yes, we have a significant increased fibrinogen concentration, but we look at more or less at long-term, 24 hours, 48 hours, there's no big difference anymore. When we look at the data on outcome, again, we see, of course, that was a small trial, overall 44 patients. So to get significant difference in mortality, I would not expect this. However, we have to be a little bit cautious, because we see that mortality was 2 times higher in the fibrinogen concentrate group. And also pulmonary embolism was higher and acute kidney injury. So that just means to me, we have to look more into details in the bigger trial, and this is more or less actually started. And the question is, if it's really the best approach to give huge amounts of fibrinogen blindly and not wait, for example, for a FibTEM A5 result, which just takes about 10 minutes. And then maybe we can improve safety by avoiding giving huge amounts of fibrinogen to patients who may not need it. There was also the factor 1 in TIC study from the group from Dietmar Fries. They even used it also in the helicopter. Also again in patients who were in severe shock and were severely bleeding, because you know Austria is much smaller than Australia from a geographic point of view, and they have a lot of helicopters just because they have to fly over the mountains, but transportation time again is not really long. However, that was also a feasibility trial, and what they could show was, we see here, that's the FibTem MCF at baseline. So we're taking blood samples all at the scene. So they were starting, of course, in both groups at the same baseline, but then the group which get placebo were dropping down with the FibTem until arrival at hospital, where the group were getting fibrinogen was stabilized or even had some increase. And that was not only for the FibTem, this was also for the XTEM. So at least you could stabilize the coagulation system until hospital arrival. And that was, again, since it was a small study, a feasibility trial, just showed this effect on hemostasis and was not looking at outcomes. The other idea is, and it was also mentioned by Dan, that they are one of the study sites for the TAP study. So also looking at 4-factor PCC in trauma. It's not completely new idea. So that's an anesthesiology paper from Oliver Grotke and Gerald Levy from 2015. And it was showing what was already done at that time. And you see 2 trials from Herbert Schöchel, one from Peter Inhofe and Dietmar Fries, 2 from our group in Essen, and just from our group in Essen, that included already 10,000 patients, which 10% got PCC. And of course, we used PCC here in the context of our trauma protocol. So that means only if we see a prolongation of XTEM clotting time, which was not based on a low fibrinogen, we treated the patient with PCC. So I think it's also not a magic bullet that we should give it to everybody, like people did years ago with recombinant factor 7A. So it was also based on a targeted approach, but not included, for example, in the randomized trial. There's increasing interest in the US also in using a 4-factor PCC, as mentioned by Dan, for example, the TAP study. And there have been some studies already published. It's cohort studies. We see here more than 500 trauma patients. And for me, a little bit funny situation is always a US up to now in studies were always giving fresh frozen PCC on top of fresh frozen plasma. And my personal point of view, it's not so difficult to introduce a new drug, but it's very difficult to take away what you were giving over 20 years before. However, when you look from a European point of view, you're really surprised, because what is the time you need to correct the INR with a combination of 4-factor PCC and fresh frozen plasma? It's 6 hours. And if you just use fresh frozen plasma, okay, it's 15 hours. So 6 hours much quicker than 15 hours. But our experience is, if we really need PCC, yeah, we correct within 10 minutes, or let's say 15 minutes. So if, of course, you first try with fresh frozen plasma, which is nearly never successful, and then you give PCC, you have still a delay. If we now recalculate mortality based on 15 minutes delay, we get a huge difference in mortality. And even this difference between 6 hours and 15 hours here ends up with a lower mortality, which was reduced from 33 to 25%, without an increase in thromboembolic events. So earlier correction of INR compared with fresh frozen plasma alone could be achieved with PCC combined with fresh frozen plasma. However, my personal point of view is, then we should do it if there's really an issue with thrombin generation, and then it just works just with PCC. There's another study, and that just shows that this is not a big surprise, that it still takes about 6 hours. There was already 10 years ago, or even longer ago, a study from the group from Hunter and Ernest Moore and Ernesto Gonzalez, which even at that time thought, oh, we have to give even more plasma, which is not effective to correct the INR, because in this study, when patient came to the ICU, there was in the pre-ICU phase no real correction of the INR, where the patient were coming to the hospital with an INR 1.6, and when they get to the ICU was 1.8, so no improvement. And then they were even getting more plasma, and it takes 8 hours more on top to the 6.8 hours before they get to the ICU to correct the INR to below 1.5. And that means you end up with nearly exactly the same time as in the recent study. It's 14.8 hours. It was 15 hours in the other study. So that means, yes, we know that fresh frozen plasma is not effective, not to correct the INR and definitely not to correct the fibrinogen level. So that's not really new information. However, there's another study also combining PCC and fresh frozen plasma from the US, a little bit less than 500 patients, but showing the same trend. That we have a reduced mortality by about 10%, and here lower rates of acute respiratory distress syndrome, because you also reduce at least the amount of fresh frozen plasma you give, and also less acute kidney injury. And there was no difference in deep venous thrombosis and pulmonary embolism. So I think, yes, it's a important tool in our toolbox, PCC. But the question is if that should not result in avoid what is not needed and just to focus on the effective products. Anyway, we will see, I think, in the next studies. There's even from the European group, and that's in principle from the cardiac group, from IACTA, but they did even recommendations for both cardiac and non-cardiac surgical patients, quite recently published, that they now say clearly there is an indication for PCC outside of warfarin reversal. It's even a license indication for Europe. Of course, not a license indication in the US, where 4-factor PCC are only licensed for warfarin reversal. That if we have massive bleeding, first point, and they have a coagulopathy, and that's an important second point, then we can start with a therapy of 25 units per kilogram body weights. In some patient population with a high risk of thromboembolic complications, and that's nearly every bleeding patient with cardiac surgery, trauma, or postpartum hemorrhage, we can also start with a lower dose. And the advantage, I think, of 4-factor PCC is that we can titrate the effect. So if we start with just 12.5 or 15, and we can see the effect after 5 to 10 minutes. If it's not enough, we can double check also what's the clotting time, and then we can redose. What they also clearly describe is what is exactly the test you should use to guide PCC. And they say it's a tissue factor activated, factor 7 dependent, and heparin insensitive point of care test, which is exactly a description of the XSTEM. It doesn't apply for RapidTech, where we know it's a combination of kaolin and a tissue factor, and there is no heparin inhibitor included. And the Quantra doesn't have an extrinsically activated clotting time at all. So it's shown also in several studies that the best assay actually from viscoelastic testing is the XSTEM to guide PCC. Of course, it has been used in randomized trials. Here's a RATIC trial you may all know. So I will just go very quickly through this trial. First of all, a very important point for inclusion was only patients with coagulopathy were included. So in all the patients, a baseline ROTEM was run. And if there was no trauma-induced coagulopathy, so there was not an XSTEM A5 below 35 millimeter, they were not even recruited for the study. And that shows, or the one reason for the big effect size of this study is that you exclude the 75% of trauma patients which are not coagulopathic. But then they were randomized in 2 groups. And in one group, ROTEM was used to guide the therapy with coagulation factor concentrates. In nearly all patients then fibrinogen, because they were all coagulopathic, in some PCC. And in the other arm, ROTEM was not used anymore, and they were just getting huge amounts of fresh frozen plasma, 15 milliliter per kilogram body weight. If bleeding was not stopped after first round, you could run a second round. If the second round failed too, they had to do a crossover. So ROTEM guided group gets fresh frozen plasma, and fresh frozen plasma after overall 30 milliliters of kilogram per kilogram body weight gets a ROTEM guided approach. And that was one of the main outcomes. So we see here on the left side, that's the ROTEM guided group with coagulation factor concentrates. Already after the first round, 76% was treated adequately. After the second round, further 20%. So there was overall a failure rate of 4% who needed fresh frozen plasma. Where on the fresh frozen plasma group, they only fixed the coagulopathy within 27% after the first round, further 21% after the second round. So overall, there was a failure rate of 52%. And that was the reason the ethics committee stopped the study early, because they said we cannot continue with an arm with more than 50% failure rate. We also see that has an impact on other blood products when we in particular look at platelets. You see that in the fresh frozen plasma arm, nearly 50% needed platelet transfusion, where only 20% needed platelet transfusion in the ROTEM guided group, which was highly significant. When we look at outcomes, we see that the massive transfusion rate was much higher in the fresh frozen plasma group with 30% compared to 12% in the ROTEM group. And therefore, I usually call ROTEM algorithms massive transfusion avoiding protocols. And when we look at safety, that was not statistically significant in this study, but you see there's more than 50% reduction in thromboembolic complications if we use a guided approach, which also avoids overtreatment. Very similar results have been published by Donat Spahn in his much bigger cohort study. So that's more than 700 patients, but the results are very similar. We see again a 2/3 reduction in massive transfusion after implementing a ROTEM guided algorithm from 12 to 4%. We see that much less plasma transfusion was used. When we look here in the emergency department from 31% to 6%, that's very close to the 4% in the RETIC trial. And when we look at mortality, 24 hours mortality dropped down from 70 to 10%, and overall in-hospital mortality from 33 to 22%. So overall, the implementation of a goal-directed coagulation management based on ROTEM and factor concentrates reduced the incidence of massive transfusion, red blood cell transfusion, fresh frozen plasma transfusion, massive transfusion, and mortality. However, it's very important to start early, not to wait that you have a massive transfusion. The concept was that you measure ROTEM as soon as possible. If you get a severely traumatized patient with bleeding in the emergency department, to differentiate between coagulopathic and non-coagulopathic. And non-coagulopathic means no plasma, no platelets, no factor concentrates. And in the coagulopathic group means you use the ROTEM results to guide your therapy. They just published a further analysis of the RETIC study with some interesting data, which is not a big surprise. As you may know, in the RETIC trial, they only based the dosage of fibrinogen on body weight. So it was more or less always about 62.5 milligrams per kilogram. Of course, some variation because they didn't give half a gram or something like this. However, what they observed in these retrospective analyses was that if the baseline fibrinogen was below 100 milligram per deciliter, or the FibTem-A10 was below 5 millimeters, then there was not a sufficient correction with a fixed dose of fibrinogen concentrate in this group. And this was associated with a need of massive transfusion. So the idea now is that we need more than just the adaptation to body weight. We should also use the baseline FibTem result to adapt the dose. That's not a new information. So we have this in our algorithm already for a long time, that we base our decision not only on body weight, but also on the targeted increase. Or you could use the baseline fibrinogen level if your target is always something between 10 to 12 millimeters. And this results in a much better adaptation of the dose, because some patients just need a relatively small dose and others need a high dose. And this is even shown in a randomized trial in cardiac surgery in neonates, also published recently from London, that you see they used FibTem to identify the low fibrinogen, but as important, they also used FibTem to adapt the dose. And that results that nearly every patient after the first intervention ended up in the target of 1.5 to 2.5 gram per liter. But you see there's a fourfold variation in the fibrinogen dose between 50 and 200 milligrams per kilogram. So I think dose adjustment is also important. And this is only possible if we measure the FibTem as baseline. And otherwise, we are a little bit blind in the dosing. And I think dosing of fibrinogen and PCC is as important as dosing of epinephrine and norepinephrine in shock. Coming back to the European studies, and to the story of TACTIC and iTACTIC, that was based on the International Trauma Research Network in Europe. There are some hospitals here in Scandinavia, in Denmark, and in Oslo, as well as in the UK and in the Netherlands and in Germany. So that was a Team Blue or Team Rotem with Karin Broe and Simon Stenders and Nicola Ufermans and Mark Megler, and Team Red for tech with Christina Gardner and Per Johansen. And they were sitting together and discussing, of course, a protocol. But first of all, they did an observational trial, and that was a TACTIC, not the iTACTIC study. And you see that was a huge study. That was more than 3,000 trauma patients to develop the protocols. Also, not big surprise the data they got, but they wanted to base their final protocol on relatively big data. There's also one interesting point. What is the difference between the TEC and ROTEM protocol is that with the FibTem, we have a very good reduction of the platelet noise. So we knock out more or less 90% of the platelets, where you see you get twice the number in the TEC function fibrinogen. That just means this result includes 50% platelet noise. And if you have relatively high platelets, that underestimates the platelet contribution and overestimates the fibrinogen contribution, which results in different decision makings. However, this is something just to keep in mind. Now we're coming to the iTACTIC study. That was the randomized interventional study in a little bit less than 400 trauma patients. They were not, as the RETIC trial, selected that they only include the coagulopathic ones. So that was all patients who get to the emergency room and the activation of a massive transfusion protocol was considered. And they had to order red blood cells. So the primary outcome was 24 hours after injury, whether the patients were alive and free of massive transfusion or not. That was a little bit triggered by the proper trial because they see the biggest difference in the early phase. And that was the reason to use 28 days mortality as a secondary endpoint. From my point of view, it's more important that the patient is still alive after 28 days and not only after 24 hours. But in studies, you have to decide what is the primary endpoint, and there can only be one. And of course, they did at the secondary endpoints also pre-specified subgroup analysis for the primary as the secondary endpoint, and also were looking at symptomatic thromboembolic events. So what are some points which I think important besides these primary and most important secondary endpoints? What they also showed was that, again, which is not a big surprise, that viscoelastic testing was quicker than standard lab tests. It's 21 minutes difference. So they were quite straightforward with the standard lab tests. And also viscoelastic testing identified more patients with trauma-induced coagulopathy than the standard coagulation group. However, if you read the paper, you find this information only in the electronic supplemental material. What we see here is a primary endpoint, and that was a little bit at the first view disappointing because it ends up not with a significant improvement in survival and no massive transfusion within 24 hours. But we have to keep in mind 75% of these patients were not coagulopathic. And we see just a quite good trend in this direction. That was a patient with severe traumatic brain injury. They had a 2 times better survival. However, due to the relatively small number of coagulopathic patients with severe traumatic brain injury, this was not statistically significant here. And of course, overall, it was not. When we look at the secondary endpoint, 28 days mortality, which for me is maybe even more important than 24 hours mortality, we see there's a better discrimination between the coagulopathic and non-coagulopathic. And again, it's not a big surprise that the coagulopathic patient had a better improvement when Rotem or TAC was used. And when we look at the odds ratio now, they have nearly a 2 times better survival compared to the patient who only gets standard lab tests. And when we look at severe traumatic brain injury, you see that even the odds ratio for mortality is down below 0.3. So that's a 3 times better survival, and it's even already statistically significant. But it was a little bit strange with the reviewers and editors by this publication. This is only mentioned in the electronic supplement. They were not allowed to say this, that there was a significant improvement in survival for severe traumatic brain injury in regard to the 28-day mortality in the abstract of the original paper. In the end, we end up with an odds ratio for mortality of 0.84, which is a 16% improvement in mortality. This was not enough to be statistically significant in these 400 patients, considering that only 100 patients were coagulopathic in this study. So what are the information we have from other studies about traumatic brain injury? So we were also running in the big European Center TBI trial, a small interventional study, which was more an implementation study. And we see what is also not a big surprise, that even in centers, and that was the inclusion criteria, they were not familiar with Rotem before. So that were all Rotem naive centers. Within a short time, we could train them with the Rotem Sigma and implementing a clear protocol and algorithm that they get results quickly and also follow the protocol. So that means the time to result after hospital admission was 33 minutes for Rotem Sigma and 71 for standard coagulation test. Even the lab was knowing that we were running the study. Of course, you need for blows a blood sample. So within 15 minutes, with a range of 10 to 20, they get the Rotem Sigma results. And it was 55 minutes for standard lab tests, so 40 minutes difference again. But maybe the most important point is here the last one. What's the time to treat after Rotem Sigma results are available? And that was 10 minutes. So that means that only works if you have your coagulation factor concentrates available in the emergency department and you have a clear protocol and not discuss half an hour what you should do with the results. And that was the algorithm we trained, a simple algorithm where is a clear indication if tranexamic acid was not already given prophylactically, which was of course possible, to give an additional dose or to give fibrinogen or cryo or to give platelets or PCC or fresh frozen plasma. And maybe the most important one was 4 times no. So that results in withhold of therapy. And you see the adhesion to the protocol was quite nice, between 87.5 and 90%. However, this study was too small to look at outcomes, but there's another study from Remaitis published some months later, where they used it also and were looking at outcome. And they also use a quite similar protocol. You see that the adhesion to the protocol was also very similar to our study in sensitive eye, but they also could observe clinical benefits, and that was the incidence of progressive hemorrhagic injury. You all know if you're bleeding in the brain, the least you want to have that it's growing, and that was reduced from 48 to 30%, and also the need for neurosurgical re-intervention was down from 40 to 13%. So that was a clear advantage for the ROTEM-guided group. Coming back to another clinical outcome, which was thrombosis. I mentioned this in the iTactic study. It was not significant. It was more or less half, but not significant in the iTactic as well as in the RETIC trial. But if we combine the data from both studies in a small meta-analysis, we see it goes down from 15 to 8%, and then also we reach statistical significance. So that means using Cox factor concentrate based on ROTEM testing definitely reduces thromboembolic complications. Coming to the limitation of the iTactic study, and we had already a lot of discussion in the planning phase, Per Jørgensen was quite strong in this group and said that we always have to start with 1:1:1, and we continue 1:1:1 until bleeding stops. However, what are the key points which are always an issue in the randomized trial? First of all, you have a time window, and the time window to include patients in the study was 3 hours after injury and 1 hour after hospital admission. So that means you don't start already in the golden hour of shock, and there is a delay, and this delay might be quite important because we know the earlier we stop bleeding, and you early we treat the coagulopathy, that has definitely a benefit. And 3 hours, that is 12 times 15 minutes. The other important issue was that 75% of the patient population, also in the iTactic study, was not coagulopathic at baseline. But this didn't result, for example, in the viscoelastic testing guided group to a withhold of plasma and platelet transfusion. So the benefit of avoiding not necessary therapy could not be seen in this study. And since only 25% were coagulopathic, so overall 100 patients, maybe the study was underpowered to show a significant result in mortality. So that means we would need at least 2 times more patients, or we have to do a better recruitment, which means have at least 50% coagulopathic patients included. And again, as I mentioned before, the ratio-driven concept was not stopped if in the viscoelastic testing group, it was shown that there is no trauma-induced coagulopathy. And that was also discussed a long time. Even the German center in Cologne with Mark Mägle, they are using 4-factor PCC in routine based on external clotting time, were not allowed in this study to use 4-factor PCC. So, of course, there's actually a new study planned or already started. The protocol is already published. That's the first 2 trial from a Canadian and US American group. That's more or less based on the first study, where they just were giving 6 grams of fibrinogen blindly. And here they start to use a combination in massive hemorrhagic trauma patient coming to the hospital, and randomize them to 4 grams of fibrinogen instead of 6, but they are giving 2,000 units PCC, or in the other arm, they're giving 4 units of plasma. Maybe it's not completely fair because 4 units of plasma compared to this cocktail is more or less, for me, nearly nothing. And the primary outcome is the cumulative number of allogenic blood products. They also, of course, look at efficiency and safety. It's planned for 350 patients, quite similar to the iTactic study. And they do a planned but adaptive interim analysis. So they can even also increase the number dependent on the effect size they see in the first 120 patients. When we look at the study concept, it reminds us to the RETIC trial. So the point is that the difference is randomization doesn't include that there is a proof that they are coagulopathic. They are just bleeding. And then they're randomized to this pack of fibrinogen and PCC, but again, not based on ROTEM results. And they can do a second round. And after the second round, if there's ongoing bleeding, they just continue with a ratio-based approach. And in the other group, they give the 4 units of plasma. And again, the 4 units of plasma. In the second pack, maybe additional platelet transfusion. And then again, continue in both arms in the same way. However, that is like call it an active control, because they were running a ROTEM in parallel, and they are allowed to give additional fibrinogen if the FibA10 is below 8 to 12 millimeters, also dependent on the dynamic of bleeding. So it's an interesting approach, yes. But again, maybe in the concentrate arm, they give also a lot of factor concentrates, maybe in a non-coagulopathic patient. But it's an interesting concept, and we will see what are the results. Finally, when we look at other studies which have been done, so you know, all the Europeans, the US people are moved out of Afghanistan, but that was also a possibility, in particular for US military and others, to also run studies, as they always do in a military conflict. And this ended up in a quite big study with 3,320 trauma patients, which have been treated in Afghanistan in the field hospitals. And they separated between patients where ROTEM or TAC was used and not. And this ended up in a nearly 40% reduction in mortality in the viscoelastic testing group. So they reduced mortality from 13 to 7%, which was already statistically significant. Also, the EAST group in the US published end of last year's new guidelines, and they did their own meta-analysis also for viscoelastic testing, and this ended up with a significant reduction in mortality for the viscoelastic testing group, quite similar to the level in the ITACTIC study. Here it was 0.8, in ITACTIC here is 0.75. So that's quite reproducible. And also ITACTIC as a part of a meta-analysis will contribute to show that there is a significant reduction in mortality. And that's something I did at the end of the last year. It's not already published, but I was looking at all the studies which have been published looking at viscoelastic testing in trauma and reporting mortality. That was 2 military studies, and mainly the study I just showed you contributed most with a risk ratio of 0.7. There are 20 civilian studies, also overall nearly 5,000 patients, ending up with exactly the same risk ratio. And of course, then if you combine all 22 studies with 8,500 patients, again, it's 0.71 as a risk ratio and highly significant. So to summarize, we have the possibility still to use a one-fits-all approach, or we move to precision medicine. Of course, one-to-one-to-one is a no-brainer, and you don't have to be very intelligent to follow this protocol. Of course, if we want to do goal-directed therapy, we need more data and we have to use our brain. But we can help the non-hemostasis experts by providing algorithms which are quite simple to follow and also quite quick to implement, because they should be as simple as possible, but never simple as possible. And that follows also the recommendation. And as a one very important point, don't wait that your trauma patient has already a massive transfusion and then think, okay, might start to use viscoelastic testing. This is definitely too late, because the damage is already done, because the patient has already massive transfusion. So there's a clear recommendation of the European guidelines to monitor and measure to support coagulation that to be initiated immediately upon hospital admission with a 1B recommendation, because it's also important to identify the patients who are not coagulopathic to withhold unnecessary therapy. And even if we start with a ratio-based approach, we should move as soon as possible to a goal-directed strategy. And this has also a 1B recommendation. And that is just one of the potential protocols. I know there are different versions. They are usually quite close in the content. They are sometimes different in the layout. But I think it's very important to have a protocol available. If it's at the poster on the wall, it is on an app, wherever, it's best to use it, and it should be always available. That's also mentioned in a recently published expert consensus meeting from the European group with all the experts which we have in this field, with Vladimir Cherny, the president of the recently World Anesthesia Conference, Dietmar Fries from Innsbruck, Givette Bernardi from Italy, Herbert Schöchel from Salzburg. And more or less it ends up, we have to measure first, and then of course, we can give tranexamic acid already blindly, but we can think about a redosing based on the testing. And I think two important tools are fibrinogen concentrate and 4-factor PCC, because we exactly know what is inside. And based on the ROTEM results, we can provide an exact dosing, which assures that we stop the bleed, but also avoid thrombosis. Yeah, and that's the final slide. Again, I think we should keep calm. We don't get into panic. We should stop bleeding and avoid thrombosis. And if we can achieve both, this is definitely good for patients' outcome. And thank you for your attention.
Thank you so much, Dr. Gorlinger. That was a really great talk. We are out of time at this point, but I'll just ask a couple of questions to you that came through quickly before we wrap up. The first is, would you recommend using one type of ROTEM Sigma cartridge over the other for bleeding management in trauma?
To be honest, for me, it's usually a type 2 cartridge because we don't need really the UPTEM to detect fibrolysis. We can do this even with early clot firmness parameters. So we did a study in 3,500 patients showing that already with the A5, we can more or less say if there's a high chance or low chance of fibrolysis. So it's the same cutoff as for Karim-Broey, that if the XSTEM A5 is below 35 millimeters, we have some chance that they get hyperfibrolyzed. If it's higher, the chance is less than 10%. But we recognize that some patients in severe shock have a so-called endogenous heparin effect. So if we see a prolongation of the in-time clotting time, but using the type 1 cartridge, that results in a prolongation of the in-time clotting time, is then quite often wrongly interpreted as a factor deficiency, and people are giving fresh frozen plasma. But if we see that the in-time heptime clotting time ratio is higher than 1.2, this just proves that there is an endogenous heparin effect. This should usually not result in giving protamine, because that maybe even make things worse, in particular platelet function. The best therapy, if there is an endogenous heparin effect, is bringing patient out of shock. So to stabilize the patient, but it avoids unnecessary plasma transfusion when we see that the prolongation of the clotting time is just based on an endogenous heparin effect.
Great, thank you for that. Another question, what would be your preference for cryoprecipitate versus fibrinogen concentrate for trauma, as both products aren't available everywhere? And what's the difference as far as factors included?
Yeah, I think I would refer to the Australian studies for that, because in Germany we cannot do studies with cryo because it's not approved anymore since 25 years. I think in the Feisty trial and other trials which have been done about the group from James Reynolds, they showed, yes, of course, you can use both. There is a significant delay if you use cryo of about, if I'm right in mind, the 30-40 minutes, because you have to thaw it to pull it. If you use pre-thawed, I think then address this, then you have a quite huge wastage rate of cryo, which I think maybe is also not the best way. Of course, you have a difference in composition that cryo has also factor 13. That can be an advantage. It also includes factor 8 and von Willebrand factor, which I think is not really needed, also not in trauma, because we know that factor 8 and von Willebrand factor are very quick acute phase reactants, liberated from the endothelium within minutes. So that's usually not an issue in trauma. We know, but there's another setting in liver transplant, it can be an issue because factor 8 and von Willebrand factor are very important pro-thrombotic factors in patients with liver cirrhosis. So there's a US study showing that if you use cryo, in particular on top of plasma, you give so much factor 8 and von Willebrand factor, which is not needed, that you have an increased rate of portal vein thrombosis. I don't think that's so important for trauma, but that is a specific issue for the chronic liver disease patients. However, you can have sometimes a combination of both, but I think it's important in hospital. I think Nolan McDonald and Roger Browning was addressing this some years ago for postpartum hemorrhage. It's important if you're a trauma center or you have a big obstetric unit, you have to be prepared that you have at least one product available, that is fibrinogen concentrate or cryo, to address a low fibrinogen in an adequate way, because we know fresh frozen plasma is not an adequate source for fibrinogen, so we can give a lot of plasma without really improving the fibrinogen level again.
Great, thank you.
And know your product. So a lot of people even don't know what is the content of fibrinogen in cryo. And I think also in Australia, I think James explained it to me, is something like a normal cryo and a super cryo. Super cryo usually prepared by apherases, where, cryo usually has a fibrinogen content between 8 and 16 grams per liter. So huge variations, where in some cryo preparations, it's more at the higher level. So let's say between 12 and 16 grams per liter. So higher concentration, also more reproducible. But of course, with fibrinogen concentrate, we exactly know what is inside because it has a specific specification. If it's below 18 grams per liter, they can even not sell the vials because it must be between 18 and 24 grams per liter. So it's a very narrow range. So that makes, of course, dosing much more precisely than dosing based on cryoprecipitate and to predict what will be the result.
Thank you for that. And we'll do one last one before we close. What would your approach be to manage a critically bleeding trauma patient who requires volume replacement before there's time to run a ROTEM?
What we use as volume, so we don't use colloids anymore. In the beginning, we use colloids. I think the only place for colloids is really in the very, very early phase when we don't have already a capillary leakage. So sometimes we use up to 500 milliliters of gelatin in the emergency car. But, very early they start with a capillary leakage. Then there is even no benefit of a colloid anymore. But we know that colloids like gelatin and even more starch impairs fibrin polymerization. So it makes even the coagulopathy stronger. So that means we just use crystalloids, and that's also based on published evidence at the time when we just need volume. Of course, if hemoglobin is low, we always start also with red blood cells. But again, I think the most important point is to stop bleeding. And what we also use in trauma is, of course, that we tolerate for a very narrow time window, let's say 45 to 60 minutes, a hypovolemia and a relatively low blood pressure. We cannot tolerate this for hours, but the target is to stop bleeding in this quite narrow time window in the golden hour of shock, and then replace the volume. That's a change of concept than before. Before it was First law is normovolemia, but that results in particular in German emergency cars in much too much volume given already pre-hospitally. So we are creating a delusional coagulopathy. And now the first law is stop the bleed and then replace the volume once, and not giving volume again and again and again and dilute the patient and continue with the coagulopathy.
Thank you for that. Just wondering, Dr. Ellis, do you have anything to add to that, or would your approach be different in that regard? The question was, what would your approach be to manage a critically bleeding trauma patient who requires volume replacement before there's time to run a ROTEM?
Yeah, look, I think I suppose in real time I'd be hedging my bets that the ROTEM is cooking. So I would be perhaps wrongly delaying for that, but I would give try to limit the amount of fluid I'd be giving at that stage, unless the patient was really, I thought, bleeding to death in front of me. But even then, something like Reboa might be a better option if that's actually the case and they're dying in front of you. But I think giving some crystalloid while you're holding the fort is an option, but also giving blood as well is perfectly reasonable. And I think then again, and Klaus has rightly pointed out the one-to-one foibles, but there's no harm in starting that while you're waiting for your ROTEM, and then you can modify accordingly. And if there's one thing that's probably quite important to note, it is that we know ROTEM is relatively insensitive for platelet function, so perhaps giving red cells and platelets while you're waiting for your ROTEM to cook might actually be the best bet. And then by the time you've delivered those, maybe your ROTEM would have popped up about how much fibrinogen you need to give, and you might have been able to tailor make it perfectly, really. So that's another option.
Yeah, I think also to add, you always have to adapt your strategy to your local situation. And there can be very different situations between Australia as a huge country with sometimes very long transportation times, and Germany as a very short ways to go. And this may be also reflected in the two studies which have been published in the US about pre-hospital use of plasma. So there was one from Sperry using plasma in the helicopter with relatively long transportation times. There was some benefit giving pre-hospital plasma. However, there's also a strong limitation in this study because that was plasma versus nothing. So maybe it was even really the volume effect during the transport, where in Denver, they were using pre-hospital plasma in emergency cars, within the city with short transportation time. And you see exactly the opposite result, that there was a trend for more mortality in the ground-based transportation, where in the air transportation, there was some benefit. I think it doesn't matter what is the way you transport. It's more important what is the transportation time. And of course, if we have a very long transportation time, as I said, we cannot tolerate a hypovolemia over 3 hours. There's a narrow window how we can tolerate this. But again, if you have longer transportation times, of course, you have to also address the hemodynamics earlier than if you can transport the patient in 10 to 15 minutes and tolerate the low blood pressure for this time, but then fix the problem as soon as possible. So again, this is something always to consider. What is your also pre-hospital logistics, and that is of course completely different in Australia or in Canada compared to Central Europe.
Perfect. Thank you so much. So apologies that we've gone a bit over time. We will go ahead and wrap it up there. So that concludes tonight's Emerge event. We hope that all of you found this meeting to be interesting and insightful. Hopefully you found some information that will be useful for you in your own practice. Thank you so much for taking time out of your busy evenings to join us tonight. And of course, we want to extend our sincere thanks again to our fantastic speakers. Your talks were really interesting and will be useful for a lot of our viewers, we believe. So thank you so much to Dr. Ellis and Dr. Gorlinger for sharing your time and expertise with us. So once again, I'm Maggie Harrington, and from our whole WRFN team here, thank you so much. Take care, and we hope to see everyone next time. Thanks again.
Bye-bye.
Take care.